Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to do another 3 sets of Vivas. So, Maddie, how's things going with you?
I think they're pretty good. I think the fellowship exam practical's coming up. So good luck, everyone who's sitting. How are things with you?
Things are pretty stable. I guess just busy with clinical. But yeah, I'm going on holidays.
Oh, where are you going?
New Caledonia.
Oh, nice.
So yeah, looking forward to it. And yeah, I just said all the best to all the candidates who are sitting the fellowship exam in a couple of weeks now. So let's dive into today's episode. The first scenario is 23-year-old female admitted following a seizure at work. A collateral history suggests that she has been acting unusually for a few days before she was seen to collapse this morning with a tonic-clonic seizure. Midazolam IV 5 mg was administered by paramedics, but she continued to seize. In the ED, she was given additional midazolam 2 mg followed by 5 mg and another 5 mg, so total of 12 plus 5, 17 mg, and was loaded with Keppra or levetiracetam 1 gram IV. After 20 minutes, she continued to have sporadic seizure activity with a best GCS of 6, and subsequently she got intubated. For induction, she received propofol 180 mg IV and rocuronium 100 mg. Now, she has just arrived in your unit with a propofol infusion running at 20 mils per hour, and ventilated settings are SIMV mode, SATs of 100% with a FiO2 of 30%. Mean arterial pressure is around 75 millimeters of mercury with no vasopressor or inotropic supports. She's warm, well perfused. So can you please outline your approach to her care over the next 12 hours?
So my approach would involve an assessment to identify the cause and contributors for a status epilepticus, and then specific management to treat these causes, as well as management to control the seizures, and then the usual supportive management within ICU. So in terms of the initial assessment, this would involve history examination and investigations to identify the cause of her seizures. And there's a broad range of differentials for this. So in terms of history, this would involve looking at collateral history about her prior behaviour and prior medical conditions before this seizure. So we know that there's been some sort of behaviour changes, what this has involved, whether there's aura, whether she's had any signs of infection like recent or any increased risk of infections such as recent travel or infective symptoms, whether she's pregnant or has had any recent trauma, and then relevant past history such as if she does have a known seizure disorder or other comorbidities that might make her more likely to have a seizure, such as malignancy, endocrine or metabolic disorders such as diabetes or renal or hepatic dysfunction or hypothyroidism. Then also any drug use such as stimulants or tramadol, which can induce seizures or withdrawal, which from some agents that can cause seizures such as alcohol, benzos, barbiturates, baclofen or gabapentin. And any medications, especially things like new medications or medication changes, the oral contraceptive pill, which could increase her procoagulant risk and make her increased risk of venous sinus thrombosis, isoniazid or antidepressant, non-adherence to antiepileptics, or any medications that might lower her seizure threshold, such as theophylline, lithium, or beta-lactams. Then it'd be important to know more about what the seizure looked like and whether there was any associated trauma from it. And then looking at her exam for potential causes as well as complications from her seizure activity. So her vital signs, pupils, for whether there's any hippus or whether there's any signs of a toxidrome, like if they're dilated or pinpoint, any focal neurological deficits, which would make me think more likely be something like a space-occupying lesion or something focal intracranially, any signs of trauma, and then any signs of any infection like neck stiffness or signs of like autoimmune diseases or pregnancy or any signs of ongoing seizures. And then investigations would once again be bedside bloods, imaging, and then some special tests. So bedside tests would involve an ABG, which will just give us a baseline status on this patient, including her ventilatory status, her glucose electrolytes and lactate, which might give us a clue about ongoing seizure activity. ECG for prolonged QRS and sodium blockade toxicity, UA and chest X-ray as part of a septic screen, and an LP for infective as well as autoimmune causes. Bloods would involve a septic screen, organ function, beta-HCG, drug levels if she's on antiepileptics, and a drug screen. I would definitely do a CT brain in this lady and then consider an MRI depending on ongoing findings from assessment, and then an EEG to clarify whether she has ongoing seizure activity. And then the management's mainly looking at the management of the status epilepticus, and which would be aiming to identify whether she is having ongoing seizure activity and terminate this as soon as possible. So this would involve EEGs and continuous EEG, ideally, depending on the resources available and if the seizure activity is not obvious, or if there's ongoing abnormal neurology or refractory status. And then treatment would be in liaison also with the neurology team, and this would involve a stepwise approach of anti-epileptics. So initially starting with midazolam and continuing a propofol infusion as well as a midazolam infusion, and further anti-epileptic therapy. Because she's already been given a gram of keppra, I'd give further levetiracetam 20 milligrams a kilo up to a max of 60 milligrams a kilo. And if she's still seizing, adding either valproate or phenytoin or lacosamide. And then if it remains refractory, considering things like a thiopentone coma, titrating to burst suppression on an EEG, or ketamine 1 to 10 milligrams a kilogram an hour. And then there's other super refractory treatment options, including things like a ketogenic diet, lignocaine. But generally this would be if the initial therapy was not effective. And obviously, as part of the management, treating the underlying causes, so antimicrobials if there's CNS infection, delivering an IV magnesium if it's eclampsia, and then reducing the risk of further seizure activity by neuroprotective measures, which aim to avoid reducing the seizure threshold, such as maintaining normoxia, normocapnia. And then obviously the usual ICU housekeeping therapy, like liaising with her next of kin, nutrition such as NG feeds, ensuring adequate access. And then if there's no contraindications on CT scans and an LP has been done or not planned, then starting chemical DVT prophylaxis.
Yeah, that's right. So that's a very comprehensive answer for approach to the management in this patient. Now, with regards to status epilepticus, can you list some of the prognostic factors that will determine the outcome of this patient?
So the prognostic factors are an older age. Which is in the case for this lady, if she had multiple comorbidities, the etiology of status. So there's a better outcome if it's secondary to previously diagnosed epilepsy or alcohol withdrawal, but worse outcome if it's secondary to a stroke, hypoxic brain injury, or there's an unknown cause, or it's an infective etiology. If there's any focal neurological signs at onset, if there's an increased duration of the status, or if the person has complications from status or from the ICU treatment, that confers a worse prognosis.
That's great. So this question often comes in ward-round discussions. Obviously, this patient requires EEG to diagnose status epilepticus. But what's the kind of role of continuous EEG monitoring in this patient's management?
Well, I think this is still being elucidated, and if you ask different intensivists, you'll get different responses. But I think for me, it depends on the patient population and the resources available at your hospital. So if we think about why we want to do a continuous EEG, is that we know that the prognosis is worse with increased time spent in status, and therefore timely identification and management of status is crucial. But intermittent EEG, which is usually what most facilities have, only captures a short period of time during which the patient may or may not be having seizure activity. Plus, it might be confounded. Any obvious seizure activity might be confounded by things like neuromuscular blockade, or if it's not obvious seizure activity. So continuous EEG increases the likelihood of detecting non-convulsive seizure activity, and also can be used to titrate sedative agents and anti-epileptic therapy in real time. So hopefully minimizing the adverse effects from unnecessary or prolonged treatment for the status. In terms of patient population, we don't really have clear guidelines from Australia, but there are recommendations from places like the American Clinical Neurophysiology Society and ESCICM, which in their guidelines recommend continuous EEG for persistently impaired consciousness that persists after initial treatment of seizures. And this is because non-convulsive seizures are relatively common in this population. They also recommend it for clinical paroxysmal events suspected to be seizures, and this is to help clarify if they're ictal or non-ictal, because we want to balance the risk of treatment with the risk of ongoing seizure activity. So things like hippus, nystagmus, episodes of tachycardia might not actually represent seizure activity. Refractory status epilepticus is or suspected non-convulsive epilepticus, and this is both to identify the same like whether they're still seizing and to evaluate the response to therapy, and if using neuromuscular blocking agents or deep sedation. But we also have to consider the resources available in our own institution. So it depends on access to continuous EEG in your unit. And it's not only just having the facilities to do the continuous EEG, but also having trained personnel who can interpret and then act on the information that you've received. And it is resource intensive and it's not readily available in most units. I know it's not available in the unit I'm currently working at. And there are many sources of potential artifact within the ICU, which might theoretically cloud some of the data that you receive.
Yeah, that's correct. I guess the last 2 points that you mentioned are often the key barriers to perform continuous EEG in ICU, lack of expertise to interpret, and also the interference with the ICU monitoring. There is little value in terms of how the outcomes change, because really, if you're really trying to achieve the burst suppression as a part of the management in the refractory status, then yes, there might be a good value or argument to institute continuous EEG. But otherwise, I think it's going to be very difficult to justify the resources and act on information that most of the people might not be able to interpret. So let's move on to the next aspect of the status epilepticus, that is the complications associated with the management of status epilepticus. So what are those kind of some of the complications that you see in ICU?
So I think you can divide this into complications secondary to the medications used to treat status, the complications secondary to the status itself, and then general complications secondary to the ICU stay. So in terms of secondary to the medications, we can think about this in terms of organ systems. So from a cardiovascular perspective, hypotension is very common, and this can be secondary to the sedation use, such as often propofol infusions, can be secondary to phenytoin infusions, especially if given over a short duration, and it can be secondary to barbiturate. Arrhythmias can happen secondary to potassium shifts with thiopentone, or to ketamine, or to vasopressors used to counteract the hypotension we previously talked about from sedatives. And then glucosamide, for example, can cause PR interval prolongation, which can also cause arrhythmias. And then propofol infusion syndrome, it's a potential complication with the propofol infusions we use sometimes for sedation for status. In terms of neuropsychiatric adverse effects, there's many that are secondary to anti-epileptics, which can seem kind of counterintuitive, but some anti-epileptics can cause agitation, somnolence, behavioural changes, neuropathy, and ataxia. Immune responses or immune adverse effects, so hypersensitivity reactions, DRESS, secondary to anti-epileptics, immunosuppression secondary to thiopentone, metabolic adverse effects including hepatic toxicity and hyperammonic encephalopathy, such as with valproate, or hematological complications such as platelet dysfunction secondary to valproate. And then the status of itself can cause adverse effects. So CNS adverse effects include intracranial hypertension and neuronal injury. Respiratory adverse effects include neurogenic pulmonary edema, aspiration pneumonitis, cardiac, including Takatsubos, autonomic dysfunction and arrhythmias. Metabolic, including rhabdomyolysis and renal failure if the status is prolonged and it's convulsive, and pyrexia. Heme, you can get DIC, and then there's the trauma secondary to the seizures itself, so things like tongue biting, fractures, and shoulder dislocation. And then we have the general complications secondary to ICU stay, because patients with status, especially refractory status, are often heavily sedated and in ICU for a prolonged period. They can get things like delirium, PTSD, critical illness, weakness, vocal cord dysfunction if they're intubated for a prolonged period of time, and atelectasis, increased risk of DVTs and PEs, and infections such as ventilator-acquired pneumonia, also due to the immunosuppression that they might be receiving. And then things like pressure areas, risk of polypharmacy from the medications, and then complications from things like line insertion and procedures that we do within the ICU.
Thanks, Maddie. So another controversial area is the role of hypothermia in the management of status epilepticus. Can you outline the rationale and evidence behind the use of hypothermia in this refractory status epilepticus?
So, as you mentioned, it remains controversial, and it's only really considered practically in super refractory cases of status, because we know that refractory status has a high associated morbidity and mortality, and it remains challenging to treat. And we know that hypothermia has anti-epileptic properties. It decreases the cerebral metabolic demand and oxygen consumption, and it reduces excited toxicity and increases the seizure threshold, thereby providing potentially some cerebral protection as well as reducing the risk of further seizure activity. It potentially decreases secondary injury and decreases neuronal apoptosis and preserves the blood-brain barrier. But the evidence we have is initially largely from animal models, and the main trial that people refer to is the Hibernatus trial from 2016, which was in the New England Journal of Medicine. And this looked at 11 French ICUs. There were about 268 patients who had convulsive status epilepticus requiring mechanical ventilation, and they were randomized to normothermia versus 32 to 34 degrees, so hypothermia. And the primary outcome was a GOS of 5, so a survival with no or minimal neurological deficits. And they found that there was no actual significant difference in the primary outcome for all the secondary outcomes, such as mortality, seizure duration, or length of stay. However, the number of reported adverse effects were higher in the hypothermia group, but progression to EEG confirmed status was lower. There were several limitations with this trial. So it was used in all patients requiring invasive ventilation rather than in refractory cases, which is generally not something that we do stand as a standard. And only about a quarter were actually in status at the time of randomization. So it's unclear how applicable this is to the usual practice and our usual population. Also, we don't know what the utility of having just a 24-hour hard limit of hypothermia is, regardless of whether the patient is still in status. And the time it took to attain the hypothermia was a median of 5.2 hours, which out of 24 hours. So they weren't actually in the target range for the whole 24 hours.
Yeah, I agree. And I think over the period of time, I think we realized there's not much role for hypothermia in intensive care in most of the conditions. So status epilepticus is another one.
Yeah, I think we're just going more to target like avoiding fever and targeting normothermia in most conditions that previously were considered maybe hypothermia might have a role.
That's correct. So let's move on to the second case. You are asked to review a confused 65-year-old female with ischemic heart disease, COPD, and atrial fibrillation in the emergency department who has presented with now abdominal pain and vomiting. Her vital signs include temperature of 39.5 degrees Celsius, respiratory rate of 30 breaths per minute, sats of 92% on 15 liter per minute oxygen via non-rebreather mask, heart rate of 120 beats per minute in AF, blood pressure of 88/48 millimeters of mercury. And this is after receiving 4 liters of 0.9% salines. She's also icteric and has right upper quadrant tenderness and mildly confused. So what is your differential diagnosis in this lady?
So I think this lady most likely has ascending cholangitis or some form of biliary sepsis. Other differentials are mainly infective, but there is a lower risk of a non-infective cause of her presentation. So infective causes include things like cholecystitis, hepatitis, EBV or CMV, liver abscess or sepsis with multi-organ failure. And non-infective causes include inflammatory conditions such as acute pancreatitis with biliary obstruction, decompensated liver failure from any sort of underlying cause like alcoholic liver disease or hepatitis, a perforated viscus with intra-abdominal sepsis, drug overdose including things like paracetamol or MDMA, vascular causes such as hepatic arterioischemia, Budd-Chiari, or intrahepatic hemorrhage, as she might be on anticoagulation due to her AF, autoimmune causes like HLH, or cardiogenic such as right heart failure secondary to ischemia, PE, pulmonary hypertension from a severe COPD, or some sort of cardiogenic shock with biventricular failure.
Yeah, that's correct. So how would you evaluate this lady's presentation?
So again, with any evaluation, it involved a targeted history. We've already done an examination, but then investigations aimed at ascertaining the cause of this lady's illness with consideration of the differentials I've just previously outlined. So I think my main priority would be on imaging of the biliary system given her presentation. In terms of history, I'd want further information about her presenting complaint and especially associated infective symptoms, the timing of her deterioration, the characteristics surrounding her abdominal pain, any bowel or bladder symptoms such as change in colour, and any infective symptoms or unwell contacts or travel. Her background, which might make one of these differentials more likely, so any history of gallstones or pancreatitis, her drug use or alcohol history, allergies, any other IV drug use, tattoos, malignancy, her severity of her COPD and her ischemic heart disease, and previous history of biliary disease or procedures, and her medication history, including whether she's on any anticoagulants, any medications known to be hepatotoxic or have caused idiosyncratic acute liver failure, such as NSAIDs, amoxicillin, or tricyclics. And then investigations would be bedside bloods and imaging. So bedside, including an ECG to look at for signs of right heart strain or ischemia, an ABG to look at her lactate for signs of shock and liver impairment and her oxygen and ventilatory status, given also that she's on 15 litres, electrolytes and her acidosis and sugar, especially if concerns about her hepatic function, and her urine MCS to look for signs of infection and presence of bilirubin. And then bloods are mainly looking at her organ function, so UEC and LFTs, a full blood count for her platelets for liver disease, the three lineages of white cell count and her HB and her red cell count, and looking for things like HLH. Coags to look for anticoagulation activity and liver disease, troponin for ischemia, and ethanol and paracetamol levels if there's a suspicion of an overdose or toxin, as well as blood cultures as part of a septic screen and lipase for pancreatitis. And then imaging would be a chest x-ray to look at her lung fields given her hypoxia, as well as the presence of free air under the diaphragm. And then imaging of the biliary tract, which ideally would be an ultrasound of the gallbladder if readily available, or otherwise a CT abdomen, and also bedside echo evaluating her cardiac function.
Yeah, so you mentioned about the ultrasound. So ultrasound of the abdomen shows a dilated common bile duct with an enlarged edematous gallbladder. Can you please outline your key management principles for this patient based on this information?
Yeah, so this lady most likely has acute cholangitis, and she's got signs of multi-organ impairment requiring urgent stabilization and management targeted at source control with biliary decompression. So my management principles include optimizing her hemodynamics, her respiratory parameters, providing source control, and then logistic and supportive care. So in terms of her hemodynamics, she requires central access, arterial line and IDC and full monitoring. I would not give her further IV fluids. She's already had 4 litres and is hypoxic. So I'd be starting noradrenaline, aiming a MAP of over 65 and adding vasopressin if high dose NORAD was required. I wouldn't give any specific treatment for her AF at the moment. I'm just ensuring her electrolytes are optimized and that she wasn't given any anticoagulation and reversing any anticoagulation, given that she most likely will have a procedure. If she remained in AF with a rapid ventricular rate despite source control and resolution of fever, I'd consider amiodarone or digoxin. In terms of optimizing her respiratory parameters, she's currently in respiratory distress requiring a non-rebreather, and I think she will require intubation given her shock, respiratory status, confusion, and the likelihood of needing a procedure, either ERCP or a percutaneous decompression. So I would continue her regular inhalers, AIM sats of 92 or more, and normocapnia or baseline CO2, her normal baseline CO2 if she's a CO2 retainer, and would either place on high flow nasal prong to preoxygenate or temporize, or continue the non-rebreather mask depending on how she's progressing. And I don't think she'd be unlikely to be suitable for NIV given that she's vomiting and confused. In terms of source control, I'd start broad spectrum antibiotics with tazocin and then rationalise in the next 24 to 48 hours depending on the culture results in her procedure. An urgent discussion with gastro and to expedite an ERCP or plus minus a sphincterotomy or percutaneous decompression given the severity of her cholangitis. And then in terms of logistics and supportive care, she'll require admission to ICU. Ideally, this will be done via OT for decompression, depending on what time it's available, and then would make sure she remains nil by mouth, currently review down the track regarding time of nutrition, aiming the normal BSL parameters of 6 to 10, try and reduce her fever. So maybe stat dose paracetamol may be regular depending on her LFTs, and just aiming normothermia, and then monitoring her organ function, mechanical DVT prophylaxis for now, and instituting a PPI.
Yeah, that's great. So let's move on to the third case for today. An obese 65-year-old male ventilated patient who has been ventilated in ICU for 10 days with community-acquired pneumonia. And now the decision has been made to proceed with performing the tracheostomy. Can you please describe the preparation, indications, contraindications, and the equipment required prior to commencing a percutaneous tracheostomy in ICU?
So a good resource for this is there's an ANZIC's consensus statement on it, but the indications can be broadly divided into airway maintenance and prolonged ventilation. So in terms of airway maintenance, for upper airway obstruction or inability to protect the airway, and for prolonged ventilation, if the patient has prolonged dependence on mechanical ventilation, whether this is actual or anticipated, such as in the case of a traumatic brain injury, to aid in secretion management, or for permanent or long-term airway access in traumatic or neurological diseases. In terms of contraindications, these can be anatomical, pathological, or due to a lack of consent. So anatomical issues could be any anomalies at the front of the neck, such as anterior neck masses or aberrant vessel anatomy. If there are difficult landmarks, so if there's significant obesity, short neck, previous neck surgery, or radiotherapy, which will distort the anatomy and might make percutaneous techniques challenging. If there's difficult airway or inability to safely manage the airway, or if there's an unstable C-spine injury or inability to extend head. So all of these anatomical issues might make a surgical tracheostomy more preferable. In terms of pathological contraindications, if there's severe hypoxic respiratory failure, if there's an infection at the site of the insertion point, severe hemodynamic instability, coagulopathy, or if it's an unsurvivable illness. And then finally, if there's lack of consent from the patient or next of kin. In terms of the preparation, we can divide this into preparation in terms of patient, location, staff, and then equipment. So from patient, we need consent. We need to review the indications, the patient anatomy, airway grade, and their hematological and cardiovascular status, and ensure that there's no contraindications to tracheostomy. We want to make sure that they're fasted, so no solids or feeds for the last 6 hours, no anticoagulants, and that the DVT prophylaxis was held that morning, that they're adequately pre-oxygenated. So generally we put them on FiO2 of 1 on the ventilator and an appropriate ventilator settings for after paralysis, and that they should be fully monitored, which include all SATs, blood pressure, ECG, and tidal, sedated and paralysed, and that positioned appropriately, so that which is supine with their neck extended. This is generally done in ICU in their bed space or somewhere where there's adequate space and lighting. And in terms of staff, it varies from institution. In our institution, we have the presence of 2 intensivists. But in terms of roles, there's an airway person managing the airway and monitors the patient and the anaesthetic. And they must be skilled at managing an airway, including responding to deteriorations or emergencies such as dislodged tubes. Someone on bronchoscopy, which is not always the case in each institution. Some people do both the airway and the bronchoscopy. So this is to identify the correct position of the needle and the guide wire and trachea position. The proceduralist, which is generally a senior trainee and or intensivist with appropriate experience, and generally at least 2 nursing staff to monitor, to be runners for equipment and help out with equipment. And then in terms of the equipment, there's the airway equipment, trachea equipment, and drugs. So the airway equipment is usually the airway trolley, which includes equipment for re-intubation if required and adjuncts for the airway and for emergency airway access, a bronchoscopy for guidance, as well as a laryngoscope, and then the emergency or rest trolley. The tracheostomy equipment, so different institutions use different sets, but usually there's an insertion kit, a sterile field, lidocaine with adrenaline, and then the trachea dressings, and then the drugs, which include sedation and paralysis, and then all the emergency drugs, including vasopressors, medications for intubation, and medications in the event of an arrest.
Thanks, Maddie. So obviously, we prefer to perform percutaneous tracheostomy in ICU compared to surgical tracheostomy. So what are the advantages and disadvantages of this technique?
So the advantages are mainly logistically, it can be done at the bedside. So there's no transport required, which we know comes with extra risk. It doesn't require a lot of the personnel that a surgical tracheostomy requires. So it doesn't require surgeon, anaesthetist, or any OT time, which might be hard to get depending on your hospital. It's also less expensive and faster to perform. We know that in terms of complications, there's a decreased incidence of bleeding, stoma breakdown, tracheal stenosis, and infection, and that it is a smaller incision, so there's better cosmesis. In terms of the disadvantages, it does have a high incidence of anterior tracheal wall injury and posterior wall perforation, as it's not done under direct vision as such. If there is a significant procedural complication, it does require surgical attendance and transfer to OT. And there's no things like diathermy available in the case of significant bleeding, and there's no stay sutures, which often are present when surgical tracheostomies are inserted. We don't have true direct visualization except for the needle guide wire and the guide wire if we're using bronchoscopy. And then there's some unique risks secondary to the insertion technique, such as wire loss, kinking or fracture, damage to bronchoscope, tracheal or cricoid fracture, false passage, conversion to an open procedure, esophageal injury, or the lateral placement of a tracheostomy.
Yeah, that's great. Previously, used to think that every single patient with a C-spine injury will be contraindication for percutaneous tracheostomy. But over the period of time, I think those contraindications have been softened, and I think we've started doing more and more percutaneous tracheostomy, even in the difficult subset of patients. So that's the end of our today's episode. But I think before we finish off, I'm pretty sure Maddie has got her favorite part of the podcast.
Yeah, you almost forgot. This one's from Jules. He wasn't sure if it would be appropriate, but I found it quite funny. So we'll see how it goes. So what kind of liver ailment did Ebenezer Scrooge suffer from? Ebenezer Scrooge, he's a miser basically. And then he gets visited by like the ghosts of Christmas present and Christmas past and stuff that shows him the error of his ways.
Okay.
This is not going to make any sense to you. Okay, so what liver ailment did Ebenezer Scrooge suffer from?
Ammonia?
No. Chronic hepatitis.
I think it was way beyond my capability.
I see. It's one of those, like, you have to know who he is. And
yeah, but that's okay, Maddie. Well done. And thanks to Jules for making my life more and more difficult. So we'll be back in months' time with another episode. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.